Thank you for joining me today. In this video, we are going to learn more about bipolar disorders. We are going to learn the diagnosis, treatment, and symptoms. And stay tuned. Bipolar disorders are characterized by recurrent episode of manic, hypomanic, and depression. This illness significantly impair the occupational function, interpersonal relationship, cognition, overall quality of life. So bipolar disorder affects a person's ability to work, ability to have a meaningful relationship, ability to have a cognition, normal cognition, and it affects your overall quality of life. Unlike major depression disorder, bipolar disorder include a period of elevated mood, happiness, and increased energy that require different treatment approaches. Misdiagnosis is a common, especially when the patient initially presented during the depressive episode, often leads to inappropriate antidepressant medication and monotherapy that may precipitate manic or rapid decline. So bipolar disorder has a 3 episode. Bipolar disorder has a manic, which is high energy and elevated mood, and it has low energy, which is hypomanic, and it also has a depression. That's why it's bipolar. You will be having a high mood, you will be having a middle mood, and you will be having a very low mood. The goal of treatment for bipolar disorders are to achieve mood stabilization, to prevent relapse, to reduce the suicidal ideation, to restore psychosocial function, to improve medication adhesiveness, to manage medical and psychiatric comorbidities. So the goal of treatment for bipolar patient is the goal of the treatment for the patient with bipolar is to achieve a mood stabilizer. So to be normal mood, stable mood, not highs, manic, or low depression, to prevent relapse. Mostly people with bipolar disorder, when they discharge to the community, majority of them, they relapse and come back to the hospital. At least in my experience, they come back to the hospital because they stop taking their medication, stop following the doctor recommendation. So the treatment is to stabilize the mood, to prevent the relapse, to reduce suicidal ideation, to restore a psychosocial function, to improve medication compliance, and manage medical and psychiatric conditions. So bipolar has a type 1 and type 2. Type 1 is at least one manic episode lasting at least 1 week. So if you remember bipolar 1, that means 1 week. Manic, one episode of manic that lasts 1 week. Or any during required hospitalization. So it's one episode of manic, 1 week, one hospitalization, or any hospitalization. Major depression episodes frequently occur but are not required for diagnosis. So there is a major depressive episode, but it don't require hospitalization. Manic episode characteristics. What are the manic episode characteristics? Manic episode characteristics include elevated, extensive, and irritable mood. Elevated happiness, champion, expensive. They spend a lot of money shopping, buying stuff, and elevated mood. They are happy, they are goal driven, they want to achieve everything at 1 week. And they are irritable because their energy is high and agitation, aggression, and anger is higher. Also, increase goal-directed activity. They want to achieve everything in 1 week. They want to graduate 1 week. They want to travel 1 week. They want to publish books 1 week. They want to do everything 1 week. So they are increased goal-directed activity. And inflated self-esteem and grandiose. So they are grandiose and inflated self-esteem. They are high emotion. They are high emotionally, they are high for their goals, they are high their energy, they are high and high. High in abnormal, not normal like other people, but that is abnormal. Decreased for sleep. Because they have all this energy, they have insomnia and decreased need for sleep. They have a pressure speech because of all this energy. They have a racing thoughts. They are destructive. Their behavior, their thoughts, their action are destructive. It's not healthy way. Excessive spending. They have a ability to have, because they want to reach, because they think they are the richest man in life, they wanted spending and spending and spending and spend. Sexually indiscretion, because they cannot control what is risky and what is not risky. So they have that sexual indiscretion. They have a high behaviors. They are in psychosis. Sometimes they have a psychosis episodes, and the psychosis may occur. They may have a delusion, hallucination, because they have a grandiose thoughts. They may think they are God. They may think they own the country. They may think they are the CEO of this company. That's what they will tell you, and that's what they believe. Hospitalization is often necessary. So they need a hospitalization for their safety and their behavior. They need to be stabilized. They need mood stabilizer. And there is a bipolar 2 disorder. Bipolar 2 disorder required to diagnose, it requires at least one hypo episode, low episode, at least one depression episode, no history of manic. So they at least have to have one episode of hypomanic episode, one episode of major depression. The first one was only manic, no depression. This one has a low manic, hypomanic, and it has a major depression episode, but no history of manic. Hypomania lasts at least 4 days and does not cause marked functional impairment or psychosis. So they don't have psychosis or impair function in bipolar 2. So it's less than severe than the bipolar 1 disorder. Depression is usually more disabling than the hypomania. They have a hypomania and depression. So the hypomania episode is not severe like the mania, but the depression is more. The depression episode is more severe and it's usually more disabling than the hypomania. It affects or it can impair the functional ability, like occupation, like school, like relationship. It can affect that, and it's depression. There is a depression involved. And there is the other one is a cyclothymic disorder. Cyclothymic disorder. Cyclothymic disorder is at least 2 years, and it happens to the adults, and 1 year for the children. So this one, which is the cyclothymic disorder, it lasts 2 years for the adults and 1 year for the child. No multiple episode happens. So it has a multiple episode. It lasts 2 years for the adult and 1 year for the child. Multiple episodes of hypomanic and depression symptoms that never meet fully characteristic for mania or major depression. So This one is not manic or depression, it's in between. And it lasts 2 years for the adult and 1 year for the children. So the mood episode combination. Mania, it lasts greater than 7 days. Hypomania lasts greater than 4 days. Depression lasts 2 weeks or greater. So mania 7 days or greater. Hypomania 4 days or greater. Depression 2 weeks or greater. So hospitalization, mania is common to be hospitalized. Hypomania don't need to be hospitalized. Depression sometimes. Psychosis may occur in mania, psychosis never occur hypomania. Psychosis may occur in depression episode. Severe impairment of judgment can happen in mania, and it can happen depression. So depression affects your judgment, cognition, and mania affects your cognition. However, hypomania do not affect your cognition. Mania has increased energy. Hypomania also has increased energy. Depression has no energy or low energy. Sleep is affected. Mania remarkably decreased. Sleep also decreased in hypomania. However, sleep may not affected. Sleep may affect depression, but sometimes it increases, sometimes it decreases. So depression has, some people has more sleep because they're depressed. Some people may not sleep and they lose ability to sleep because they're depressed. So depression, sleep fluctuates different for person to person. However, mania, everybody has decreased sleep, and hypomania is the same. Clinical presentation is manic symptoms. Patient often present with euphoria, happiness, irritability. They are agitated, irritable, impatient. They are grandiose. They think they are the CEO, they are the doctors, they own millions of dollars. They have grandiose feeling. Excessive confidence. They have excessive confidence in themselves that is abnormal, which is not true. which is not what I mean. They believe something is not applied to them. They are hypersexual. They have increased energy. So everything is increased. Spending. They spend sprees, like shopping. They thousands of dollars credit cards because they think they are rich, because they think they have all the money in the world. They spend it and spend it and spend it. They are risk takers. They start multiple projects. Because they think they can accomplish that. They have pressure speech. They have a fights of idea, lot of idea coming every direction, lot of ideas. They have a decreased sleep and appetite. They are agitated and angry sometimes. These are clinical symptoms of manic. However, what is the clinical symptoms of bipolar depression? Because bipolar has depression and manic. The symptoms include sadness, hypomania, they cannot sleep, low motivation. So it's opposite of what we talked about in manic. Hopelessness, SIs. So it is opposite of what the manic is. Unlike unipolar depression, bipolar depression frequently include mood liability, so highs and lows, psychomotor retardation. A typical feature is psychiatric symptoms like hallucination, delusion, disorganized thoughts and behavior. Bipolar, it's family history of a bipolar. So people who have a bipolar disorder, they have first or second relative who also have the bipolar disorder. Bipolar depression increases SI risks approximately 50%, 25 to 50% attempt. Risk increases during the depression episode, mixed episode, early illness with substance abuse, when they are already depressed, and if they take in medication that increase the risk of SI. Recent hospitalization can also increase the risk of SIs. So what are the first line of treatment? First line of treatment is treatment depends on the recurrent phase. acute manic. Are the patient having acute manic? Are they bipolar depression? Are they in maintenance therapy? So it depends. If the patient is having acute mania, the treatment is lithium. Lithium is the gold standard of mood stabilizer for manic episode. Lithium mechanism is modulates dopamine, glutamate inhibitor, and secondary messenger effects. So it affects secondary messenger, inhibit glutamate, and moderates dopamine. The dose of lithium depends, but it is between 900 to 1,800 milligram daily. Therapeutic level of a lithium is 0.8 to 1.2 immaculate liter in acute. Advantage of a lithium include it reduces SI for depression, for manic episode. It prevents relapse. Effective for classic mania. So lithium, the benefit of taking lithium for manic patient is it reduces SI, it prevents relapses, and it's effective for classic manic. However, the side effects include tremors, polyuria, which is peeing more, weight gain, hypothyroidism. Those are the side effects of a lithium. Renal dysfunction. So lithium affected the thyroid, affected the renal function. It increases the weight. It causes tremor and it affects the nerve system. And it increases urination. What do you need to monitor? You want to monitor the lithium level, BMP, creatine for kidney function, TSH for the thyroid, and you want to do pregnancy test. Next is fulbaric or defulbaric. Next mood stabilizer called valproate. Valproate is medication that especially used for mixed episode, rapid circulating, and aggression. So valproate is a mood stabilizer. and especially useful for mixed episode, rapid circling, and aggression if the patient is experiencing or exhibit those behavior. Dosage is in between 750 to 2,500 milligram a day. Therapeutic level is between 50 to 125 milliliter. Side effects include weight gain, tremor, hair loss, liver hypertoxicity, liver damage, and pancreatic inflammation, thrombocytopenia. So you want to monitor the white blood cell, you want to monitor liver enzyme, you want to monitor drug level, and you want to avoid pregnancy when you are taking this medication. Carbamazepine is other mood stabilizer medication. It is useful for mania, mixed episode, and aggression. So if the patient has aggression, if they have a mania or mixed episode, they can have carbamazepine. The dosage of carbamazepine is between 400 and 1,200 milligram daily. You want to monitor the white blood cell, sodium level, liver enzyme, major risks for taking this medication include aganoclotosis, which is it affects the white blood cell. It causes Stevens-Johnson syndrome, and it lowers the sodium level. Second generation antipsychiatric medications may work rapidly for mania. So if the patient has a manic episode, they can have second generation antipsychiatric medications. Example of those second generation antipsychiatric medications that the manic patient can have include Risperdal, olanzapine, Seroquel, aripiprazole, ziprasidone, cariprazole. Those are second generation antipsychiatric medications. Advantage of taking this secondary antipsychiatric medications include rapid symptom control. So if the patient is manic and having all the symptoms that we talk about, you want to use the second generation antipsychiatric medication because it will control those symptoms and it is treat the psychosis. If the patient having a psychosis like hallucination, depression, delusion, psychosis symptoms like hallucination, delusion, disorganized status, and aggression. So advantage of second generation antipsychiatric medication include rapid symptom control, treatment of the psychosis episode, and treatment of the agitation. You want to monitor the weight gain because second generation antipsychiatric medication leads to weight gain. It increases the glucose or diabetic. It increases the lipid. It increases EBS symptoms. It also affects the QT prolongation. It's also agent dependent, which means some of them have that QT prolongation. So in nutshell, second generation antipsychiatric medication can affect your weight, can affect the blood sugar, can increase the blood sugar, can increase the weight, can increase the lipid or fat in the system, can increase the EBS symptoms, which is movement, muscle movement, abnormal muscle movements, and it can affect the heart. Bipolar, we talked about that. We talked about the mania. However, the bipolar depression episode is unlike the unipolar depression. It is antidepressant should not be used alone because they may induce mania and rapid cycling. So if you use the bipolar depression, if you use the only antidepressant medication, it can make the patient manic. So you cannot use only antidepressant medication. Preferable medication include Seroquel. Seroquel is FDA approved for bipolar depression. Dose is 300 milligram at night. Seroquel improves the depression, anxiety, and sleep. Latuda is also approved for bipolar depression episodes and can be combined with lithium or valproate. Latuda dose ranges between 20 milligram to 120 milligram a day. It has a minimum effect on metabolic, so you don't gain weight. You don't increase your appetite. It has a minimum effect on weight gain. Carbarazine effective for bipolar depression. Valar, that's the other name, Valar. Valar is a typical antipsychiatric medication, and it treats bipolar and schizophrenia. And it is effective on bipolar depression. Lamictal is excellent maintaining a medication. Lamictal. It's best for preventing a relapse, and it can slowly titrate to higher dose. However, it has a serious risk of Stevens-Johnson syndrome, which is the rash, skin discoloration. Combination of olanzapine and fluoxetine combination is useful for bipolar depression, and it has a higher metabolic risks. That means it increases the weight, increases the appetite, increases the lipid, increases the diabetic risks. Maintenance therapy. There is a maintenance therapy, which is a long-term treatment aimed to prevent a future episode. So maintenance therapy is used to prevent a relapse. So the maintenance therapy medications include lithium, lamotrigine, Seroquel, aripiprazole, cariprazine are the maintenance, and maintenance often lasts for a long time or for life, because the bipolar can last forever. What are the psychotherapy treatment? We already talked about the psychopharmacology treatment, and we want to talk about the psychotherapy. Psychotherapy, medication alone is rarely sufficient. So we want to use the medication with the psychotherapy. Combination psychotherapy with the pharmacotherapy reduces the relapse, improves medication compliance, and enhances the quality of life. Psychoeducation is the fundamental of the treatment for bipolar disorder. Psychoeducation is recommended for all patients and the family because the family will involve their loved ones. It helps individuals to understand bipolar disorder as a chronic illness require ongoing treatment. The goal of psychoeducation is to improve understanding of the bipolar, increase medication compliance, taking their medication adhesiveness, identify early warning signs of a manic or depression, develop relapse prevention strategy, reduce stigma, encourage healthy lifestyle. Those are the goals for the psychoeducation. Core component is recognize triggers. You want to teach the patient what are the triggers of bipolar disorder, how you know if the bipolar episode is coming. The stress can trigger the bipolar disorder and the relapse of a bipolar disorder. Sleep deprivation can lead to relapse or bipolar depression or bipolar disorder. Substance usage can increase the risk of a bipolar disorder relapse. Importance of maintaining a regular sleep and daily routine. You want to teach the patient a daily routine and maintaining a regular sleep. Family education regarding a symptom recognition. If the patient cannot recognize the family are around and they can know this, they can tell if they are educated the symptom is and the relapse sign is, they can seek treatment earlier, they can intervene with their loved ones. You want to teach them the crisis and the safety plan. Second, psychotherapy is cognitive behavior therapy. Cognitive behavior therapy helps patient identify and modify a maladaptive thoughts and behavior that combine to mood episodes. Cognitive behavior therapy is indicated for bipolar depression, reduced depressive symptoms, anxiety disorder, medication adhesiveness difficulty. Techniques of cognitive behavior therapy include cognitive reconstruction, behavior activation, mood monitoring, problem solving skills, coping strategy for stress. Benefit of cognitive behavior therapy include it reduces the depression symptoms, it improves the function, it better recognize of the mood changes. It will help the patient and the family to recognize the mood changes. It lowers the relapse rate when combined with the medication. Interpersonal and social rhythm therapy. Interpersonal and social rhythm therapy focus on stabilization of the biological rhythm, improve interpersonal function, it improves interpersonal function, and the rationale is disruption in a sleep and daily routine. So that is what is good for and can precipitate those can precipitate disrupted sleep and daily routine can lead to manic episode or depression episode. So the goal of this treatment is to maintain consistent sleep cycle schedule, regular meals, and daily activity. You want to schedule, you want them to have routine, you want to manage the role transition and grief. This is good for that. Personal, interpersonal, social rhythm therapy is good for managing a role transition and grief, regulation meals and activity, maintaining consistent sleep, reduce stress triggers. Clinical benefit of this therapy is fewer mood changes, long-term episode of long-term period of a remission. So you wanted them to have long-term without mania or depression. So this will help them improve occupational and social function. Also, the other therapy is a family-focused therapy. Family-focused therapy involves both the patient and the family members to improve the communication and reduce the conflict. And the component of a family-focused therapy include education about the bipolar disorder, communication skills training, problem solving exercise, relapse prevention plan. The benefit of this therapy include reduce excessive emotional within the family, improve medication adhesiveness, lower relapse, and hospitalization rate, increase family support, because they need a family support to remind them their medication, to remind them the symptoms, to remind them the appointment, to be there for them, to support them. So you want to educate the family and the patient. Dialectical behavior therapy is also beneficial, although the original development for bipolar personal disorder, DBT, can benefit patients with bipolar disorder who have significant emotional dysregulation and SI behavior. So dialectical behavior therapy core skills include mindfulness, distress tolerance, emotional regulation, and interpersonal effectiveness. And clinical application of this therapy include chronic SI, self-harm behaviors. It's beneficial to patient who is having a chronic SI or self-harm or impulsive or co-occurrent personal disorders. Group therapy is also beneficial for bipolar disorder. Group therapy improves peer support, promote recovery through a shared experience. And the benefit of the group therapy include reduce isolation, enhance coping strategies, improve medication adhesiveness, strengthens education for the illness, encourages healthy behavior. Motivation interviewing also is beneficial for bipolar disorder. It is especially useful for individuals with poor insight, poor understanding of their situation and understanding of the bipolar disorder. It amplifies toward the treatment and coping strategies. The goal of this treatment motivation interviewing is increasing motivation. You want to increase the motivation, and this will help with that. Improve treatment engagement. Address medication non-adhesiveness. Improves compliance with the treatment. Reduce substance usage. Supportive psychotherapy is also beneficial for bipolar disorder. Supportive psychotherapy emphasizes the strength, coping mechanism, and improves emotional support. Focus area for supportive psychotherapy include stress management, encouragement, validation of experience, reinforcement of adaptive coping skills, problem solving. Those are the focus areas of the supportive psychotherapy. Lifestyle and relapse prevention include successful long-term management of maintaining a regular sleep schedule, avoid alcohol and illicit drugs, exercise regularly, eat a balanced diet, manage stress, monitor mood with journal and apps. You want to write down your mood and how you're feeling. Take medication constantly the way it's being prescribed. Keeping a regular psychiatric follow-up appointment. Involve supportive family members or caregivers. Those can help the patient to have a meaningful quality of life and prevent relapse. Special clinical considerations include pregnancy. You want to avoid pregnancy or use caution when taking valproic due to teratogenic, so it's poison or affect the fetus. You want to avoid getting pregnant. Lithium may also cause selective cases with fetus. You want to monitor the mother and fetus closely. Treatment decision should be balanced. Relapse risk with the you want to weigh the risk with the benefit. For pregnancy women, giving pregnancy women with lithium or valproic. For elderly adults, initiate medication at low dosage. You want to initiate the medication lowest dose possible and then titrate slowly, increase slowly. You want to monitor the renal function, liver function, and cognition function closely. Watch for drug interaction and increase sensitivity to side effects, because older adults are more sensitive to drug than other adults. Occurring substance use disorder. If the patient have bipolar and then they have substance abuse that can affect them, treat both conditions at the same time. Incorporate motivation interviewing and relapse prevention strategies. Coordinate psychiatric and addiction service when possible. You want to coordinate them, you want to treat them at the same time. Clinical takeaways include always screen for bipolar disorder or always screen a past manic or hypomanic before prescribing antidepressant medication. Because if the patient already had hypomanic or manic, antidepressant medication can make it worse, so you want to screen that. Antidepressant medication monotherapy is generally avoided in a bipolar 1 disorder because it makes the bipolar more worse and creates manic. Lithium remains the only mood stabilizer consistently associated with reduction of SI. Psychoeducation and medication. Psychoeducation and consistent medication adhesiveness are the key for long-term stabilization. Regular sleep, often one of the earliest, so sleep disturbance. Sleep disturbance is the first sign of bipolar relapse and the warning sign of manic. Combination of psychotherapy, psychopharmacy, and lifestyle modification and regular follow-up provides best outcome for bipolar disorder. Bipolar disorder requires lifetime individual treatment. Bipolar disorder is a lifetime and require individualized treatment. Mood stabilizer like the lithium, fulburic, and lamartine, and selective antipsychiatric medication form a key psychiatric management. So the treatment psychotherapy include psychoeducation, cognitive behavior therapy, family focus therapy, deductive behavior therapy, psychotherapy, psychopharmacology, and lifestyle changes will help with the maintaining quality of life, prevent relapses, and improve mood and stabilization. Stable mood. Having a stable mood. Thank you for joining me today. I would love to see you in my next video. Please subscribe. Thank you.